I'd like to introduce Dr. KP KUDLU, a member of the GC and editor proceedings. All to you, KP.
Thank you, Sonu, for the opportunity. Thank you, Sanjay sir, letting me go earlier. Thank you, all the panelists. I think most of the people are genius in Feki KUL, so my job has become much easier. No financial interest as far as this presentation is concerned. So I think all these factors, patients who are not suitable for LASIK, all these factors I'm not going to talk. So I'll be telling few features of the iClick Feki KUL, which has got excellent visual outcome, easy to load, easy to implant, and presence of both central and peripheral hole, and very less chance of flip and rotation. So what are the advantages with these lenses? We all know that which is far from the endothelium and close to the nodal point of the eye, stable location, does not alter the shape of the cornea, and which is completely reversible. So these are the A list. Already all our previous speaker has been done about how to know about ACD. But this is one point I wanted to tell. We did one comparison. The most accurate ACD will get either from A-scan or IOL Master 700 or best is ASOCT. So A-scan is comparable with ASOCT and IOL Master 700. But I always do with the ASOCT or with the A-scan. Then white to white is the single most measurement which has been bearing the success of the procedure. 2 to 3 reading normally we take. Oversizing causes a high vault, which causes glaucoma. Undersizing causes lower vault, which causes cataract. Again, we have done one small study, which is the best of the for white to white. If you calibrate digital caliper, that gives the best of the best result in comparison with the old model of orb scan. So undersizing causing low vault, as I said that, long-term effect, it can cause a cataract. So if you see, we have done some of the, one of the, just now Sheetal Brar has left from here. She has presented compared with the vault of star ICL with the iClick Feki KUL that showed the mean height of the central vault showed reduction over time, but none of the eyes in either group developed cataract due to the low vault. So both the results are comparable, both star ICL with the iClick Feki KUL. So let us come to the lens changes for a longer term. So as I already said that if there is lens changes, again it is depending upon if there is a low vault. So as the age progresses, lens keep changing also. But if you are having a high vault, always you can expect them to have a glaucoma. So because high vault, there is a mechanical contact between the ICL and the iris, mechanical compression, shallow AC, inflammation, high IOP, angle closure glaucoma, and that gives to pigment dispersion syndrome. See, these are the complications can happen with the high vault. So I am not going to talk with any of this point. So these are the one point I want to take. We need to look at the long-term effect on the corneal endothelium. The rate of endothelial cell reduction in normal eyes is between 0.6% per year. Thus, endothelial cell loss after Feki KUL implantation mainly a result of surgical procedure itself, not with the Feki KUL implantation. So you need to remember. So average of 6.2% of endothelial cell loss was reported in 8 years of following ICL implantation. One of the study from Igarashi et al. But some of the other studies shows that Toran et al. Studies show that 5.8% of the endothelial cell loss average 7 years after the PRL implantation. So this is about the how even it can happen with a patient with the chronic uveitis too. So regression, of course, normally as the age progresses, the regression can happen. The Igarashi noted that significant myopic regression after ICL implantation in 8 years follow-up study. Similarly, other study shows that myopic shift 7 years after the ICL implantation. So long-term predictability regarding the iClick Feki KUL implantation, long-term predictability, 67% of the eyes were within 1 diopter of attempted spherical equivalent. The reason why 33% were outside the scope of 1 diopter of the attempted correction could be caused by generation of myopic regression. So of course, long-term of risk of RD is mainly due to the RRD is caused by the pathophysiological alteration, that is high myopia, rather than a complication with the implantation of posterior chamber PCI Feki KUL. This people has to remember. So the other complication with the myopic CNVM, which is the high incidence in the high myopic, one of the cases report that CNVM 4th, 8th or 10th year after the ICL implantation, because that is due to the pathological myopia, not with the ICL implantation. Of course, induction of corneal astigmatism, I want to compare normally ICL will go through the 3-point incision where the phakic acryl phakic goes to the 2.8 incision. We need to study the level of astigmatism induction will be much lesser with the acryl phakic lenses. This is about the rotational stability. Normally rotational stability occurs for 5 degree in 17% of the patient. Then less than 10% were seen in 3 years in most of the cases. That is again with the, not with the cases, the report are with the rotation stability both equally with the ICL and the other lenses. So these are our experience with the acryl phakic regular one, 200 patients. If you see here, I think this is a hydrophilic material. You see patients, most of the patients are between the range of between -10 to -15 diopters. If you see 46% of the patient has got a spherical equivalent between 0.5 to -0.1. Then wow factor, if you see, almost around 95% of the patient, and 20/16, almost 90% of the patient. So again, IOP stability is almost normal. So as I said, that patient achieving post-op uncorrected equal or near to the preoperative best corrective visual acuity. Endothelial cell loss was around -3.1. And also, none of the patient developed cataract or iris deformation. None of the patient required IOL explantation also. Only 18 patients had an initial rise of IOP, which has been controlled by medication and equally stopped. These are a few results of our acryl phakic toric. So 132 patients. These are the, I am not going to talk about the different models. So this is the overall results. Patients coming after 6 months of follow-up. If you see here, more than 95% of the patient had a refractive astigmatism less than 0.5 diopter. That means the rotational stability is very stability with this patient. 88% had a less than 5 degree rotation, and all eyes less than 10 degree rotation. That you could able to see. In conclusion, acryl phakic and acryl phakic toric IOLs are phakic lenses are safe and effective for treating range of myopia and myopia with astigmatism. Short and easy learning curve for cataract surgeon. Quality of vision is always better than promise. Again, I thank my brother Sonu for this wonderful opportunity. Thank you one and all.
Thanks, KUDLU, for bringing out that long-term outcomes. I think that reassures us that over 20-25 years that we have been using, this lens tests the stand of time. I think that's quite reassuring.